Hey, pediatric team, let's talk bones, balance, and braces. Welcome to the deep dive.
Glad to be here.
We're jumping into a really crucial and complex area of pediatric health today, the musculoskeletal and neuromuscular systems.
Yeah, it's fundamental stuff.
We've pulled together some really rich sources, articles, research notes, clinical guides, just packed with insights on everything from, how bones grow, which is
It
fascinating,
really is.
and the unique way kids get fractures, all the way through congenital conditions, systemic challenges like juvenile arthritis, and, well, those inevitable sports injuries.
Uh-huh.
Our mission in this deep dive, to kind of unpack it all for you, distill what's most important and help you feel confident, well-informed about supporting mobility, muscle tone, and just overall skeletal health.
Absolutely. It's a system that's constantly changing, always growing, and it presents unique challenges and, frankly, incredible resilience in children.
Right.
We want this deep dive to be your shortcut, sort of, to understanding not just the what, but the why behind pediatric musculoskeletal health.
Okay, let's start with the foundation then. We're talking about the body's amazing hardware bones, muscles, joints, tendons, ligaments,
All the moving parts?
and the nervous system, which is like the software telling it all what to do. What's truly fascinating here and really foundational to understanding kids is that this whole system starts off mostly as soft cartilage during fetal development.
Right, before it gradually hardens, ossifies into bone.
And that difference, the fact that it starts as cartilage and is actively growing, that's key, isn't it?
Oh, absolutely key. Pediatric bones are fundamentally different from adult bones. They're more resilient to certain types of stress, believe it or not.
More resilient, how so?
Well, you have this thicker, highly active outer layer. It's called the periosteum. They have a tremendous ability to reshape themselves or remodel, and they heal remarkably faster than adult bones, much faster.
So unlike a mature bone, a kid's bone might just bend under pressure instead of snapping clean through, like literally bow.
Exactly. You see those bowing fractures or green stick fractures, incomplete breaks, where the bone is splintered on one side but still kind of intact on the other. And often in kids, the ligaments and tendons around a joint are actually stronger than the nearby bone tissue, especially near the growth plate.
So instead of tearing a ligament like an adult might,
Right, instead of a sprain or a tear, the child might get a fracture near the joint instead. The bone gives way before the ligament does.
and this periosteum you mentioned, that thick outer layer, you said it's a big player in healing.
It is. It's super rich in blood supply and the cells that form new bone. That's why it stabilizes fractures so well and really accelerates healing. It's almost like nature's internal splint system.
This rapid healing sounds great, shorter times in casts, maybe.
Definitely an advantage, yeah.
But I bet there's a flip side, a potential complication.
There is. Because they heal so fast, if those fracture fragments aren't properly aligned, they can solidify incorrectly really quickly. So getting good alignment right away is critical.
Makes sense.
But the upside is that incredible remodeling potential. The body can actually absorb old bone and lay down new bone, gradually straightening out mild bends or angulations that happen during the injury.
And I remember hearing this remodeling is best when the child is younger, more potential.
Precisely. The younger the child, the more remodeling capability they have, especially for that mild angulation where the bone is angled instead of straight.
Okay.
However, rotational deformities where the bone is twisted, those usually don't remodel correctly on their own. They often need some help, some intervention to get them aligned properly.
Right.
And here's a slightly surprising insight. Sometimes, a fracture near but not actually in, the growth plate can actually stimulate extra bone growth in that limb.
Really? Make it longer.
Sometimes, yeah. It can lead to a small difference in length over time. Just something to be aware of.
Interesting. Speaking of growth plates, that's the physis, right? The engine of long bone growth.
It's it, the physis. It's that area of cartilage at the ends of the long bones where all the new bone cells are produced, making the bone longer.
And because it's cartilage.
Because it's cartilage, it's often the weakest point in the whole bone ligament unit in kids. So an injury right there, a growth plate fracture, is particularly concerning.
Why specifically?
Because it can potentially disrupt future growth. It could lead to the limb growing crooked or ending up shorter than the other side. Long-term consequences.
So understanding those growth plate injury classifications, the Salter-Harris types, and the potential long-term effects is really important for follow-up care.
Absolutely critical. And then once the cast finally comes off, what can caregivers expect? Well, kids usually bounce back quicker than adults. They typically don't get as stiff.
That's good news.
It is. But they still need time. Usually a few weeks, maybe 1 to 3, for a gradual return to full activities. They need to regain strength and coordination. The bone is still finishing its transformation, from that temporary fibrous callus into strong, permanent bone.
And activity restrictions are key during that period.
Super key point for family education. No contact sports or activities that could cause a hard fall or impact for at least 2 to 4 weeks after the cast is removed. Even if they feel totally ready,
Got it.
the bone is still vulnerable.
Okay, let's move from the general principles to navigating some specific conditions and injuries you might encounter. Fractures are probably the most common reason a child lands in the orthopedic clinic, right?
Oh, definitely,
But
right. Let's start with some really frequent ones. Torus fractures, sometimes called buckle fractures, are super common.
that's the foot one.
Often, yeah. Think of falling on an outstretched hand, that Fuchs injury. The bone gets compressed and just sort of buckles outwards, often near the wrist, but doesn't break all the way through.
So the wrist looks a bit swollen and painful,
Yep.
but maybe not dramatically deformed.
Exactly. Another tricky one is the occult fracture, like a toddler's fracture in the tibia, the shin bone.
Occult meaning hidden.
Yeah, basically.
But
You might have a young child, just started walking, who suddenly refuses to walk or is limping badly, but the initial x-ray looks completely normal.
oh wow.
The fracture line is often hairline or a faint spiral and just doesn't show up clearly yet.
So how do you diagnose that then, if the x-ray is clear?
Often, it's based heavily on that clinical picture. The sudden onset, limp, or refusal to bear weight, maybe some very subtle swelling or tenderness right over the bone. Sometimes you'll see the healing callus, like a little cloud of new bone, on a follow-up x-ray a couple of weeks later.
And treatment.
Treatment is often just focused on providing pain relief and immobilizing it, maybe with a walking boot or a simple cast for a few weeks. That helps with the pain, too.
And what about those incomplete breaks you mentioned earlier, the green stick ones, where it splinters on one side?
Right. Green stick fractures, they're partial breaks where the bone bends on one side and cracks or splinters on the tension side.
Yeah.
Also typically managed with casting to hold it straight while it heals.
Okay. And wrist fractures generally, distal radius.
Distal radius fractures, yeah, just very common overall in falls in kids. Treatment really depends on how shifted or displaced the broken pieces are and the child's age. But casting is the standard approach for most.
Elbow fractures sound more complicated, though. You mentioned they're a significant chunk.
They definitely are. Elbow fractures make up about 15% of all pediatric fractures. It's a complex joint, multiple bones coming together, and those immature growth plates are particularly vulnerable there.
And the big one is the supracondylar.
Supracondylar fractures, yes. Just above the elbow joint. They're the most common type, peaking in kids around 5 to 7 years old.
And these ones have reputation for needing really close monitoring, right?
Absolutely critical.
Yeah.
A displaced supracondylar fracture, where the pieces have shifted significantly, can easily compromise the brachial artery or the nerves running right through the elbow.
Okay, that sounds serious.
It is. You must check for the 5 Ps. Pain out of proportion. Pulse, checking the radial pulse of the wrist. Pallor, paleness or coolness of the hand.
Yeah.
Paresthesia, numbness or tingling in the fingers. And paralysis, inability to move the fingers.
And if any of those are present.
If there's any hint of compromised circulation, like a weak or absent pulse or significant nerve deficit, it's an immediate orthopedic emergency. It needs prompt reduction, putting the bones back in place, often surgically, to restore blood flow. Most displaced ones end up needing surgery to pin them internally.
Wow, okay. What about other elbow fractures?
Well, you also see fractures of the condyles. Those are the bony knobs at the end of the humerus, the upper arm bone.
Mm-hmm.
Medial condyle fractures on the inner side of the elbow are sometimes linked to overuse, particularly common in adolescent baseball pitchers from that repetitive throwing motion. Little league elbow sometimes involves this area.
Right, overuse injuries.
And lateral condyle fractures on the outer side are often from falls. Again, treatment depends on how displaced they are, ranging from just casting to surgery if they're shifted.
Okay. Clavicle fractures, collarbone breaks seem incredibly common too, like you hear about them all the time.
They are extremely common. They happen a lot, even during birth sometimes, if it's a difficult delivery.
Wow.
The good news is most heal really, really well with just a simple sling for comfort. The bone ends might overlap a bit, but usually remodels beautifully, especially in younger kids.
So surgery isn't usually needed.
Not usually.
Yeah.
You just need to watch for specific signs like the bone fragment pushing hard against the skin, what we call tenting, or any signs of nerve or blood vessel issues underneath, which are rare but might indicate a need for surgery.
And parents should know a bump might remain.
Yes, absolutely. A little bump often remains where the bone healed, that callus formation. It usually smooths out over time, but might stay noticeable.
Okay. Tibial fractures in the shin bone, also frequent from twisting falls, you said.
Right, and again, the toddler's fracture comes up here, that non-displaced spiral fracture in a young walker. Important pattern to recognize.
And you mentioned spiral fractures can sometimes be a red flag.
Yes. It's always important when you see certain fracture patterns, especially spiral fractures, in an infant who isn't walking yet, or maybe corner fractures, tiny chip fractures, where ligaments attach, sometimes seen with shaking injuries, to carefully consider the possibility of non-accidental trauma or child abuse.
That's a crucial point for any pediatric team to remember, really vital.
Absolutely. Moving up the leg, femur fractures the thigh bone. These usually require significant trauma in older kids. Think car accidents, major falls. They're serious injuries.
Right.
But similar to the tibia, a femur fracture in a non-walking toddler, especially if it's spiral or a corner fracture type, must raise concerns for abuse and needs thorough evaluation.
Treatment sounds like it would be more involved for femur fractures compared to, say, a collarbone.
Oh, definitely. It is. Because it's such a major weight-bearing bone, treatment focuses on restoring length, alignment, and rotation as accurately as possible.
What are the options?
Options vary significantly depending on the child's age and weight. It might involve traction first, followed by casting, sometimes those big spica casts that immobilize the hip and one or both legs, or various surgical methods like plates and screws, flexible nails inserted inside the bone, or even external fixators for more complex breaks.
Okay, so beyond those traumatic injuries like fractures, what about those ongoing alignment or developmental issues? Scoliosis, the curved spine, is one people often hear about.
Right, scoliosis. It's essentially a sideways deviation or curve in the spinal alignment. You might notice it during a routine well-child check or a school screening, or a parent might notice uneven shoulders or waistline.
And the forward bend test is common for screening.
Yes, asking the child to bend forward at the waist, letting their arms hang down, can often reveal asymmetry, like one side of the back being higher than the other, that's the rib hump, or just unevenness in the spine itself.
And it's not just one condition, right? There are different types.
Correct. There's congenital scoliosis, which is present at birth due to malformations in the vertebrae themselves. There's juvenile scoliosis, which appears between ages 3 and 10.
Okay.
Adolescent idiopathic scoliosis, or AIS, is the most common type by far. It develops during that rapid growth spurt in adolescence, and idiopathic just means we don't know the exact underlying cause.
And the fourth type?
And then there's neuromuscular scoliosis, which is associated with underlying conditions that affect muscle control, like cerebral palsy or muscular dystrophy. The muscle imbalance pulls the spine out of alignment.
How is scoliosis typically treated? It seems like it would vary a lot.
It does. It's very individualized. Treatment is guided mainly by the child's age, how much growth they have remaining, and the severity or magnitude of the curve, measured in degrees on an X-ray.
So small curves might just be watched.
Exactly. Small curves in growing kids are often just observed with regular follow-up X-rays to see if they're progressing. If the curve is getting worse and the child is still growing significantly, bracing is often the next step.
What kind of brace?
A common type is the TLSO brace, a rigid plastic brace that fits around the torso. The goal of bracing isn't usually to correct the curve completely, but to try and halt its progression while the child finishes growing.
And for really young kids, or severe curves.
For very young children, maybe infants or toddlers, with severe or rapidly progressing curves, sometimes sequential casting, like metacasting, is used. And if curves become very severe, usually over 40-50 degrees, and are continuing to progress, especially in adolescents nearing skeletal maturity, spinal fusion surgery might be necessary.
To straighten and stabilize it permanently?
Right, to straighten the spine as much as possible and fuse the vertebrae together to prevent further curvature. Sometimes growing rods are used in younger kids to allow for continued spinal growth before a final fusion.
Okay. What about issues with leg and foot alignment? Things like bow legs, knock knees, in-toeing. Parents worry about those a lot.
They do, and these are really common. Many often relate to how the child was positioned tightly in the womb, sometimes called packaging issues, or they're just part of the normal developmental sequence as kids grow.
Clubfoot is a well-known congenital one, though. The foot is really twisted.
Yes. Clubfoot, talipes equinovarus, is a complex congenital deformity where the foot is twisted inward and downward.
But treatment for clubfoot has come a long way, hasn't it?
It really has. The Ponseti casting technique is often incredibly successful if started very early, ideally in the first few weeks of life. It involves a series of gentle manipulations and long leg casts, changed weekly to gradually correct the foot position.
Sounds intensive.
It is, but very effective. However, the long-term success hinges critically on really strict adherence to bracing after the casting phase is done.
What kind of bracing?
Usually involves wearing special shoes attached to a bar, called a foot abduction brace or Ponseti brace, initially almost full-time, then just at night and during naps, sometimes for several years.
So compliance is key.
Absolutely key. Preventing recurrence is the major challenge. Caregivers need really good education on how to use the brace correctly and why it's so important, and also on recognizing signs of recurrence, like the foot starting to turn back in or the child walking on the outside edge of their foot. Those need prompt attention.
And what about the more common in-toeing issues, feet pointing inwards?
Right. There are a few main causes. Metatarsus adductus is where just the front part of the foot, the forefoot, turns inward relative to the back part. Then there's tibial torsion, where the shin bone itself is twisted inward, and femoral torsion, where the thigh bone is twisted inward. Both of these cause the whole foot and leg to point inward when walking.
Are these serious?
These are incredibly common, especially as kids first start learning to walk and their coordination is developing. The good news is the vast majority, probably over 90%, resolve completely on their own without any treatment as the child grows, usually by age 7 or 8. Their bones naturally rotate outwards and their walking mechanics mature.
So often it's just observation and reassurance for the family. Tell them not to worry too much.
Exactly, for most cases. But knowing when to watch versus when intervention might be needed is important. For instance, if metatarsus adductus is very severe or rigid and isn't improving, gentle stretching exercises or sometimes serial casting might be considered.
And for the torsion?
Surgery for severe, persistent tibial or femoral torsion is very rarely needed, and usually only considered in older children, maybe over age 8 or 10, if it's causing significant functional problems like tripping or pain. But again, that's uncommon.
How about genovarum, which is bull legs, and genovalgum, knock knees?
Also frequently seen, and they often follow a predictable physiological pattern. Infants are typically born slightly bow-legged, varus. As they start walking, this usually straightens out by around 18-24 months.
Okay.
Then they tend to become slightly knock-kneed, valgus, between ages 3 and 4. This knock-knee appearance usually peaks around age 4 and then gradually straightens out again to the normal adult alignment by age 7 or 8.
So that pattern is normal development.
That pattern is considered physiological, yes, normal. But persistent or worsening, bowing beyond age 2, or severe knock-knees, or asymmetry between the legs can be a sign of an underlying problem.
Like what?
Things like Blount's disease, where there's abnormal growth of the growth plate on the inner side of the upper tibia causing progressive bowing, or rickets due to vitamin D deficiency or other metabolic bone diseases. Severe knock-knees can sometimes be associated with skeletal dysplasias or kidney problems.
Does weight play a role here too, especially with Blount's or knock knees?
Significantly, yes, particularly in Blount's disease, and also in persistent adolescent knock-knees. Excess body weight puts increased mechanical stress across the developing knee joints and growth plates.
So addressing weight management can be part of the plan.
It can be a really important part of the overall care plan for some kids, yes. It highlights the need for that team approach involving nutritionists, maybe physical therapists, endocrinologists if there's a metabolic issue.
And timing matters for intervention.
Timing of any intervention, whether it's bracing, sometimes used for Blount's or severe knock-knees, or surgery, like guided growth surgery or osteotomies to realign the bone, is often critical. For significant bow legs due to Blount's, intervention before age 4 generally leads to better outcomes.
Let's talk hips now. Hip dysplasia can be tricky, you said, because it can be subtle.
It can be. Developmental dysplasia of the hip, or DDH, it can be developmental, meaning it happens around the time of birth or shortly after, not necessarily present from early fetal life. It's often subtle and can be easily missed if you're not looking carefully.
What's actually happening in DDH?
Essentially, the hip socket, the acetabulum, is shallow or underdeveloped. This allows the femoral head, the ball part of the joint, to be unstable. It might be partially dislocated, subluxated, or fully dislocated.
Are there specific things that increase a baby's risk for DDH?
Yes, there are well-known risk factors. Being the firstborn child, being female, being in a breech presentation in utero, bottom first instead of head first, having a positive family history of hip dysplasia. Also, sometimes associated conditions like torticollis, twisted neck, or certain foot deformities like clubfoot or metatarsus adductus.
What signs might you see on exam in an infant?
In infants, you might find limited ability to abduct the hip, meaning move it outwards away from the body compared to the other side. Or maybe asymmetrical skin folds in the thigh or buttock area, though the number of folds can be more telling than just slight asymmetry in appearance. There are also specific provocative maneuvers, the Ortolani and Barlow tests, used in newborns to feel for instability, a clunk, as the hip dislocates or reduces.
And how is it diagnosed definitively?
Ultrasound is the primary diagnostic tool in infants, up to about 4 to 6 months old, because the hip is still largely made of cartilage, which doesn't show up well on X-ray.
Yeah.
After about 6 months, X-rays become more reliable as the bones ossify.
And treatment, what's the goal?
The goal is to get the femoral head properly seated deep within the acetabulum so that both can develop normally together. For infants diagnosed early, usually before 6 months, the Pavlik harness is the gold standard treatment.
That's the soft brace.
Yes, it's a soft harness that holds the baby's hips in a flexed, bent, and abducted, spread apart position, kind of like a frog's legs. This position naturally guides the femoral head into the socket and encourages the socket to deepen over time. It's usually worn for several months.
And if it's diagnosed later or the harness doesn't work?
If diagnosed later, say after 6 months, or if the Pavlik harness isn't successful in keeping the hip reduced, then more involved treatments might be needed. This could include a period of traction, followed by a closed reduction, manipulating the hip back into place under anesthesia, and placement in a spica cast. Or sometimes open surgery is required to physically put the hip back in the socket and maybe even reshape the socket, osteotomy if needed.
Okay, so we've covered trauma like fractures and developmental or alignment issues. What about causes of hip pain or limping in kids that aren't straightforward fractures?
There are a few really important ones to know, particularly in school-aged kids and adolescents. One is Lenkel-Perthes disease.
Perthes disease, what is that?
It's a condition where the blood supply to the femoral head, the ball part of the hip joint, gets temporarily interrupted. We don't always know why. This causes the bone in the femoral head to die, a process called avascular necrosis, then collapse, and then slowly rebuild itself over several years.
Wow, several years.
Yes, it's a long process. It typically presents with a limp, which might be painless initially, and sometimes aching pain in the hip, groin, thigh, or even referred pain to the knee. It's more common in boys, usually between the ages of 4 and 8.
That sounds like it could really affect the joint shape. What's the goal of care?
The main goal during that long process of breakdown and rebuilding is to keep the femoral head as round as possible and well contained within the hip socket, acetabulum. This helps maintain the shape of the femoral head and the integrity of the socket, aiming for a better long-term outcome and reducing the risk of severe arthritis later in life.
How is that achieved?
Management can range quite a bit. Sometimes it's just observation with activity modification and physical therapy to maintain range of motion. Sometimes bracing or casting is used to help contain the femoral head, and in some cases, surgery might be needed to redirect the femur or the socket to improve containment. Depends a lot on the child's age at onset and how much of the femoral head is involved.
Okay. Another hip issue that causes pain and limping, especially in teens or preteens.
That would be slipped capital femoral epiphysis, usually shortened to SCFE or SCFE.
SCFE, what's slipping?
In SCFE, the growth plate, cubitus, at the top of the femur, the capital femoral epiphysis, or the ball part, actually slips off the neck of the femur, like ice cream sliding off a cone.
Ouch. When does this typically happen?
It commonly occurs during the rapid adolescent growth spurt, usually between ages 10 and 16. It's particularly common in kids who are overweight or obese, as the extra weight puts more shear stress across that growth plate. Hormonal factors might also play a role.
What are the symptoms?
They often complain of pain, which can be in the hip, groin, thigh, or very commonly referred pain only felt in the knee. This can be misleading. They also typically have a limp and characteristically walk with the affected leg turned outward, external rotation.
Why is it important to catch SCFE quickly?
Because it's often an unstable situation. The slip can worsen suddenly, leading to a more severe deformity and potentially cutting off the blood supply to the femoral head, a vascular necrosis, which is a serious complication. Even stable slips need prompt treatment.
And treatment is usually surgical.
Yes, stabilizing the hip surgically is the standard of care. This is usually done by inserting 1 or sometimes 2 screws across the growth plate to pin the femoral head in its current position and prevent any further slippage. This is crucial to reduce the risk of those long-term complications like a vascular necrosis or developing early and severe osteoarthritis.
Okay. Now, for a younger child, maybe preschool age, who suddenly starts limping, what's the most common culprit that isn't one of these serious underlying bone issues?
That would most likely be transient monoarticular synovitis, often just called toxic synovitis, although the toxic part is a bit of a misnomer.
Transient synovitis, what is it?
It's basically an inflammation of the synovial lining of a joint, most commonly the hip. It typically follows a recent viral illness like a cold or stomach bug, maybe a week or two later.
And how does it present?
It causes acute onset limping and hip pain. The child might refuse to bear weight on that leg. They might have some limited range of motion due to pain, but usually they don't appear systemically ill. Maybe a low-grade fever, but often no fever.
And the transient part means?
It means it generally resolves on its own, usually within a week or two, with just rest and maybe some anti-inflammatory medication like ibuprofen.
But it's vital to distinguish it from something much more serious that could look similar initially, right?
Absolutely critical. And these are the ones you cannot miss. They're true acute orthopedic emergencies: septic arthritis and osteomyelitis.
Okay, tell us about those.
Septic arthritis is a bacterial infection inside the joint space itself. In young children, the hip is the most common site, followed by the knee. Osteomyelitis is a bacterial infection of the bone itself, often occurring near the growth plate in the long bones of children.
How do these present differently from transient synovitis?
Children with septic arthritis or osteomyelitis are usually much sicker. They often have a higher fever, significant pain even at rest, marked swelling and warmth over the affected joint or bone, and often a complete refusal to bear any weight or even allow passive movement of the limb due to severe pain. They may have elevated white blood cell counts and inflammatory markers like ESR and CRP in their blood tests. Sometimes there's a history of a recent skin infection or other illness.
And they require immediate action, urgent treatment.
Yes, these are absolute medical emergencies requiring immediate hospital admission. Suspected septic arthritis usually needs urgent surgical drainage, washing out the infected joint, and intravenous antibiotics. Osteomyelitis also requires prompt IV antibiotics and sometimes surgical drainage if an abscess is formed.
Why the urgency?
Delays in treatment can lead to rapid and irreversible destruction of the joint cartilage in septic arthritis, or significant bone damage and deformity in osteomyelitis. In rare cases, overwhelming infection can even be life-threatening. So, high clinical suspicion based on the child's symptoms, physical exam, and lab tests is absolutely key to getting them the right treatment quickly. You have to differentiate it from the more benign transient synovitis.
Okay, really important distinction there. Shifting gears slightly now, what about chronic inflammatory conditions affecting the joints, like arthritis in kids?
Right. That brings us to juvenile idiopathic arthritis, or JIA. The idiopathic, again, means we don't know the exact cause, but it's understood to be an autoimmune disease where the body's immune system mistakenly attacks the joints.
And it's chronic.
Yes, JIA is a chronic condition characterized by persistent joint pain, swelling, stiffness, often worse in the morning or after rest, and inflammation. It can affect just one joint, oligoarticular JIA, a few joints, or many joints, polyarticular JIA, often in a symmetrical pattern. There's also a systemic form, SJIA, that involves fever and rash along with arthritis.
What are the potential impacts?
If not adequately controlled, JIA can lead to significant long-term joint damage, growth disturbances, disability, and impact the child's quality of life, school attendance, and psychosocial well-being. Sometimes can also affect the eye's uveitis, so regular eye exams are crucial.
How is JIA typically diagnosed and managed? What are the goals?
Diagnosis is primarily clinical, based on having persistent joint swelling in one or more joints for at least 6 weeks after ruling out other causes. Lab tests looking for markers of inflammation, ESR, CRP, and sometimes specific autoantibodies like ANA or rheumatoid factor can support the diagnosis. The main treatment goals are really broad: control the pain and inflammation, preserve joint function and range of motion, prevent joint damage, promote normal growth and development, and support the child's overall physical and psychosocial well-being. It requires a multidisciplinary team approach.
And the treatment options have improved, haven't they?
Oh, significantly. Treatment usually starts with nonsteroidal anti-inflammatory drugs, NSAIDs, like naproxen or ibuprofen for symptom relief. But for ongoing disease activity, the mainstay is disease-modifying antirheumatic drugs, DRNs, like methotrexate.
And the newer biologic agents.
Yes, the development of biologic agents, which target specific molecules involved in the inflammatory process, like TNF-alpha or IL-6, has really revolutionized the treatment of JIA, especially for moderate to severe cases that don't respond well to methotrexate. They can be incredibly effective at controlling the disease and preventing damage.
And physical therapy.
Absolutely essential. Consistent physical and occupational therapy is critical for maintaining joint mobility, muscle strength, and function.
You also mentioned a serious complication, MAS.
Yes, it's vital for anyone caring for kids with JIA, particularly the systemic form, SJIA, and also sometimes seen in other autoimmune conditions like lupus, to be aware of macrophage activation syndrome, or MAS.
What is that?
MAS is a severe, potentially life-threatening complication. It's basically a runaway inflammatory reaction where immune cells called macrophages become overactivated, leading to high fevers, blood count abnormalities, liver dysfunction, and other systemic problems. It requires prompt recognition and aggressive treatment, often with high-dose steroids or other immunosuppressants.
Okay, that's a lot of specific conditions we've covered. Now let's maybe pivot to the practical side. Important considerations for actually caring for kids with these various musculoskeletal issues day to day.
Right, the hands-on care. Assessment is obviously foundational. Beyond the physical exam, looking at range of motion, checking gait, assessing muscle strength and tone, those diagnostic tools we mentioned are key.
Like imaging.
Exactly. X-rays are the workhorse for fractures and checking bone alignment. Ultrasound is great for infant hips and looking at soft tissues like tendons or fluid collections. An MRI gives really detailed pictures of soft tissues, cartilage, bone marrow, often used for suspected infections, tumors, or complex joint problems.
And lab tests you mentioned.
Definitely. A complete blood count,
Yeah.
CBC, looking for signs of infection or anemia. And those inflammatory markers, erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP, are essential screening tools when you suspect infection like septic arthritis or osteomyelitis, or to monitor disease activity in conditions like JIA.
For caring for acute injuries, like a sprain or a fracture before it's casted, what are the core principles caregivers should remember, that PRICE acronym?
Exactly. PRICE is a great mnemonic for initial management of many acute soft tissue injuries and fractures. P is for protect the injured area, maybe with a splint or just avoiding use. R is for rest. I is for ice, applying cold packs to reduce swelling and pain, usually 15-20 minutes at a time, several times a day.
Okay.
C is for compression, if appropriate, using an elastic bandage to help reduce swelling, but being careful not to make it too tight. And E is for elevation, keeping the injured limb raised above the level of the heart, also to help reduce swelling.
And for a child who ends up in a cast or a splint, what's the crucial monitoring?
Neurovascular checks are absolutely paramount. You need to regularly assess the circulation and nerve function below the level of the injury or the cast splint.
How do you do that? What are you looking for?
You're checking if the child can feel you touching their fingers or toes, if they can wiggle them. You're looking at the color. Are they pink and warm or pale and cool? Check the capillary refill press on a nail bed. It should turn white, then quickly pink up again in less than 2-3 seconds. You're also asking about increased pain, numbness, or tingling. Any signs of compromise need immediate attention.
And general cast care.
Yes, teaching caregivers proper cast or splint care is vital. Keep it clean and dry. Plastic bags for bathing are essential. Never stick anything down inside the cast to scratch an itch. It can break the skin and lead to infection. Pad any sharp edges. And know the warning signs that mean the cast might be too tight or there might be a problem underneath. Increasing pain, swelling, numbness, or tingling, inability to move digits, skin discoloration, pale or blue, coolness, or a foul odor or drainage coming from the cast.
Maintaining alignment is also key, you mentioned.
Yes, especially with certain fractures or after reductions. Ensuring the child maintains the prescribed position, using pillows for support if needed, is important for proper healing.
Pain management is obviously huge in all of this.
Absolutely. Using appropriate pain medications is important, both prescribed analgesics and over-the-counter options like acetaminophen or ibuprofen, following correct dosing guidelines for children. But don't forget non-pharmacological techniques, too.
Like what?
Things like distraction games, movies, music, positioning for comfort. Applying ice packs over the cast near the injury site can sometimes help. Guided imagery or relaxation techniques for older kids, making sure their basic comfort needs are met.
And postoperative care can be complex, especially after big surgeries like scoliosis fusion or maybe for a femur fracture managed in a spica cast.
Very much so. Post-op care requires vigilant monitoring. Checking the neurovascular status frequently is critical. Managing pain effectively, often using patient-controlled analgesia, PCA, initially for older kids, or scheduled doses. Wound care, monitoring for signs of infection. Preventing complications is huge.
What kind of complications?
With prolonged immobilization, especially in a spica cast, things like skin breakdown or pressure sores under the cast edges or over bony prominences are a risk. Constipation is very common due to pain meds and immobility. Sometimes respiratory issues can arise due to positioning. So, frequent repositioning, log rolling for spine patients, meticulous skin care, ensuring adequate hydration and bowel regimen, encouraging deep breathing, these are all crucial nursing interventions.
And just supporting daily life activities.
Yes, absolutely. Assisting with activities of daily living, bathing, dressing, toileting, which can be challenging in a spica cast,
Yeah.
helping them manage mobility aids like crutches or walkers safely, and liaising with the school about necessary accommodations or restrictions on physical activity or gym class once they return. It's rarely just about fixing the bone, it's about supporting the whole child and family through the process.
This really brings us back to family education, which sounds absolutely essential given everything we've discussed. It seems like the cornerstone.
It truly is the bedrock of good outcomes, especially for chronic conditions or during long recovery periods. Caregivers need clear, consistent, understandable instructions on everything.
Like what specifically?
Everything from specific activity limitations, what they can and can't do, and for how long. How to safely use any assistive devices like crutches or braces. Critically, knowing how to recognize those red flag warning signs that require immediate medical attention, like fever with a limp, sudden inability to move a limb, signs of neurovascular compromise we talked about.
And follow up.
Yes, understanding the importance of follow-up appointments, therapy schedules, medication regimens. For chronic conditions like JIA or OI, ongoing education about the disease process, treatment goals, and potential complications is vital. Connecting families with reliable resources and support services, physical therapy, occupational therapy, social work, orthotic specialist support groups is also a huge part of comprehensive care. Empowering the family is key.
Now, here's a really interesting, maybe surprising area where medications come into play not just for treating these conditions, but potentially contributing to risk. I understand some common medications might have links to bone health or fracture risk in kids.
Yes, this is a fascinating and evolving area, and it really highlights the interconnectedness of different aspects of health. There's growing data suggesting a potential link, an increased risk of fractures, particularly in the limbs, associated with the use of proton pump inhibitors, or PPIs, in children.
PPIs, those are the common reflex medications, right? Like omeprazole.
Exactly. Medications like omeprazole, lansoprazole, they are very commonly prescribed for conditions like gastroesophageal reflux disease, GERD, or esophagitis, even in infants and young children.
And why is this link being looked into? What's the concern?
Well, the association between long-term PPI use and increased fracture risk, especially hip fractures, is better established in adults. The proposed mechanisms aren't fully clear, but they're thought that PPIs, by significantly reducing stomach acid, might interfere with the absorption of calcium. They might also affect bone cell function in other ways.
And now studies are finding this in kids, too.
Yes, several observational studies in children, including some in vulnerable populations like preterm infants who often receive acid suppression, have found correlations between PPI use and higher rates of fractures. While correlation doesn't prove causation, the consistency of the findings is raising awareness.
So what's the takeaway for practice?
It really emphasizes the need to carefully weigh the benefits versus potential risks, especially with prolonged or high-dose PPI use in children. Are they truly indicated? Can the dose be minimized? Are there alternatives? It's a significant area of ongoing research and scrutiny, given just how widely these medications are used.
Is this kind of concern also relevant with certain hormonal medications used by adolescents?
Yes. Another area getting attention is the potential link between Depo-Provera, DMPA, which is dipomedroxyprogesterone acetate, a common injectable form of birth control, and its impact on bone mineral density, particularly when used during adolescence.
Why is adolescence such a critical time for bone health?
Adolescence is the crucial window for acquiring peak bone mass. It's estimated that around half of an individual's total adult peak bone density is laid down during these teenage years, especially for young women. Achieving a high peak bone mass is protective against osteoporosis and fractures later in life.
So anything that interferes with that bone building process during that critical time could potentially have long-term effects.
Exactly. DMPA works by suppressing estrogen levels, and estrogen is known to be important for bone health. Concerns have been raised that using DMPA during these peak bone-building years could potentially lead to lower bone mineral density acquisition, which might not be fully recovered even after stopping the medication.
So what does this mean for counseling teens?
It underscores the importance of comprehensive counseling, discussing all contraceptive options, weighing the risks and benefits of each method, including potential effects on bone density with DMPA, and importantly, counseling all adolescents, regardless of contraceptive choice, about ways to support their bone health, ensuring adequate intake of calcium and vitamin D, getting enough protein, engaging in regular weight-bearing exercise. It's about providing balanced information so they can make informed choices about their health.
Okay. Switching gears again, sometimes the issue isn't an injury or an external factor, but the bones themselves are inherently fragile.
That brings us to osteogenesis imperfecta, often called OI or brittle bone disease.
What causes OI?
This is an inherited genetic disorder, usually caused by defects in the genes responsible for producing type 1 collagen. Collagen is the main protein that provides structure and strength to bone, as well as other connective tissues. If the collagen is faulty or insufficient, the bones become very brittle and fracture extremely easily.
How easily?
Sometimes with minimal or even no apparent trauma. Fractures can occur during birth, just from routine handling like diaper changes or from minor bumps and falls that wouldn't harm other children.
And sadly, this extreme fragility can sometimes be mistaken for something else initially.
Yes, unfortunately, the sheer frequency and sometimes unusual nature of the fractures in a child with undiagnosed OI can sometimes raise initial concerns about non-accidental trauma or child abuse before the correct underlying diagnosis is made. This can be devastating for families.
So awareness is crucial.
Absolutely crucial for anyone caring for children. Recognizing the possibility of OI, especially if there are multiple fractures, maybe blue sclerae, the whites of the eyes having a bluish tint due to thinness allowing underlying vessels to show, short stature, or a family history. Once diagnosed, it's vital to handle the child with extreme caution, communicate their fragility clearly to all staff involved in their care, using signs on the crib, alerting therapists, etc., and connect families with specialized care centers and resources like the Osteogenesis Imperfecta Foundation for support and information.
OI ranges in severity too, right?
Yes, it exists on a wide spectrum, from mild forms where people might only have a few fractures in their lifetime, to severe forms that are lethal in infancy due to extreme fragility and respiratory problems. There can also be associated features like hearing loss, dental problems, dentinogenesis imperfecta, and joint hypermobility. Treatment is supportive, focusing on fracture management, maximizing mobility with therapy, sometimes using medications called bisphosphonates to help increase bone density, and surgical rotting of long bones to provide internal support.
Okay. Finally, let's touch on the world of sports. Active kids get injured. It's almost inevitable sometimes.
They certainly do. As kids get older and participate more intensely in sports, we see a lot of sports-related injuries. Acute things like sprains, ligament injuries, strains, muscle or tendon injuries, dislocations.
Like nursemaid's elbow, is that a dislocation?
Nursemaid's elbow is technically a subluxation, a partial dislocation, of the radial head at the elbow. It's very common in toddlers and preschoolers, usually caused by a sudden pull in the outstretched arm, like lifting them by the wrist. It's easily reduced, but it fits that category of acute joint injury. We also see muscle tears, contusions, bruises, and fractures, of course. But very commonly in young athletes, we deal with overuse injuries.
Overuse injuries, those result from repetitive stress, right? Not one single traumatic event.
Exactly. Think about a young baseball pitcher throwing hundreds of pitches week after week, or a gymnast practicing landings over and over, or a distance runner pounding the pavement day after day. That repetitive microtrauma, without enough time for the tissues to rest and recover, can lead to inflammation and injury.
What kind of injuries?
Things like tendonitis, inflammation of a tendon, stress fractures, tiny cracks in the bone, apophysitis, inflammation where tendons attach to growth centers, like Osgood-Schlatter disease at the knee or Sever's disease at the heel, or irritation of the growth plates themselves, like Little League elbow or shoulder.
How is assessment different for these? Are you looking at their sport, their form?
Definitely. A key part of assessing overuse injuries is understanding the demands of their specific sport, their training volume and intensity, their technique or biomechanics. Are they doing too much too soon? Is their pitching form off? Do they have muscle imbalances or inflexibility contributing to the problem?
And treatment often starts conservatively.
Yes, the cornerstone of treating most overuse injuries is relative rest, modifying or stopping the activity that causes pain, along with ice, anti-inflammatories, and often physical therapy. Therapy focuses on addressing any underlying biomechanical issues, improving strength and flexibility, and guiding a gradual, safe return to sport. Sometimes bracing or temporary casting might be used. Surgery is rarely needed for most overuse conditions.
But prevention sounds like it would be really key here, if possible.
Absolutely crucial. Prevention involves multiple strategies, teaching proper technique and form for their specific sport from a young age, ensuring gradual progression of training intensity and duration, avoiding sudden big jumps in activity, emphasizing the importance of proper warm-up before activity and cool-down routines afterward.
Cross-training.
Yes, encouraging cross-training to use different muscle groups and avoid constant stress on the same tissues. Ensuring adequate rest and recovery between practices and games. Proper nutrition and hydration play a role too. And perhaps most importantly, teaching kids and adolescents to listen to their bodies, to recognize the difference between normal muscle soreness and pain that signals an injury, and empowering them to speak up and not just play through significant pain. Coaches, parents, and healthcare providers all share responsibility in promoting safe sports participation.
Wow. Okay. We have really covered a massive range of topics in this deep dive today.
I certainly have.
Starting from the just fascinating unique biology of growing bones and why they get injured differently, then exploring common fractures from buccal to supracondylar and complex conditions like scoliosis, hip dysplasia, those concerning joint infections, and chronic arthritis like JIA.
Right. And they're discussing essential care points assessment, cast care, neurovascular checks, family education being so key.
And even touching on the surprising links between some common medications and bone health, the
Yeah.
challenges of genetic conditions like OI, and navigating the world of sports injuries and overuse.
It's a huge field.
We really hope this gives you, our listeners, a clearer, more integrated picture of the challenges, the vulnerabilities, but also the truly incredible resilience of the pediatric musculoskeletal system. It's complex, it's dynamic,
Always changing.
and supporting it properly is just so vital for a child's lifelong health and
Right.
mobility.
Yeah. And as we've seen throughout this discussion, seemingly simple things like how a child sits habitually, or the repetitive stresses from their favorite sport, or even a common medication prescribed for something completely different can have significant ripple effects on their bone health or musculoskeletal development down the road.
Right.
What does this tell you, really, about the importance of seeing the whole picture when caring for children? Recognizing how everything from genetics and lifestyle to specific treatments in the surrounding environment is so interconnected in shaping their growth and well-being? It's definitely something to keep in mind to really think about in practice.
Stay strong and steady. See you in the next one. And don't forget to check out our Drug of the Week playlist for key meds to help you pass your state boards.